Well, today's speakers are Angie LaFlamme, Senior Program Coordinator on the Network TA team here at RHI, and Cap Wilkes, our Director of Program Development. I'm now going to turn things over to Angie to get us started. Go ahead, Angie.
Thanks, Becky. So welcome, everyone. Again, my name is Angie LaFlamme, and Senior Program Coordinator with the Center in RHI. Little bit of background about myself and workforce in regard to the National Rural Health Resource Center. The center's played a key role in healthcare recruitment, our healthcare workforce, and continues to be actively involved in implementing workforce strategies across the United States, specifically for primary care providers in rural and underserved communities. So for the past 20 years, I've worked with rural health clinics and hospitals on their provider recruitment and retention, assisting in developing recruitment and retention plans, sharing information and the importance of employee satisfaction surveys and the cost of turnover. I also oversaw the center's Minnesota Healthcare Provider Recruitment and Retention Service, as well as present to medical students, physician residents, and advanced practice providers each year on the advantages of a rural practice and also how to evaluate rural practice opportunities. In the past, I have assisted in providing relevant and pertinent technical assistance and education, tools, resources, and such to help support program outcomes and network sustainability for the former Rural Network HIT workforce program, and as well as do all of that same assistance for the current Rural Network Allied Health program. And so that's a little bit about my recruitment and retention experience and history. I'm going to introduce Cap Wilkes, our Director of Program Development, to introduce herself, and then we'll go ahead and get started with the webinar.
Thanks, Angie. This is Cap, and hello to folks. It's good to be here on the webinar with you today. Workforce really is an important part of how organizations succeed, of course, and the aspect of my speaking to you today is particularly related to workforce engagement and focusing on managing change. I've been talking to networks for a good number of years about change and also teach at an organization development course with the Rural Health MBA program at the College of St. Scholastica. So I have both empirical and practical experience along with and combined with the academic and theoretical knowledge of managing change and how that specifically relates to workforce and staff engagement. So I'm looking forward to sharing and talking with you about change and the stress that it brings to folks, plus the good news that we have for staff engagement. So back to you, Angie.
Great, thanks, Cap. So we'll go ahead and jump right into our presentation. First, just a little bit about Rural Health Innovations. RHI is a subsidiary of the National Rural Health Resource Center, which is a nonprofit organization, and together RHI and the Center are the nation's leading technical assistance and knowledge centers in rural health. In partnership with the Center, RHI connects rural health organizations with innovations and enhances the health of rural communities. Our objectives that Cap and I are going to cover today with our presentation is to assist you in considering the importance of employee satisfaction and hope that you'll gain an increased knowledge of healthcare workforce recruitment and retention planning. We'll also share a little bit about the William Bridges transitions model and also how to explore retention-focused infrastructure that will support long-term workforce solutions. So we hear so much about the decrease in the supply of our healthcare providers across the country. We have a shortage of primary care physicians, RNs, pharmacists, behavioral health providers. Therefore, with the shortage becomes a demand for these professionals, and that demand continues to increase, and recruitment is becoming more and more competitive. There are several factors that impact our healthcare provider supply and demand, and I'm sure you're all quite familiar with some of the common factors, such as we have a growth in population, we have an aging population, we have a population of baby boomers that have started to retire now and will continue to do so over the next several years. We have an increase in insurance coverage. So more people now have health insurance than in years past, which means more people are going to the doctor and having procedures done. With that aging population as well, you know, we've got these baby boomers who are retiring, which means that is going to increase our demand for those providers. We also, as our population ages, typically when you age, you need to see a physician more often, and so that is also helping or adding to the demand or the need for more providers. And there's also a lack of the availability of training programs. And so we don't have enough training programs to train as many healthcare providers as we are currently in need of. So here we'll look at some supply and demand numbers for 7 different types of healthcare professionals, ranging from physicians and pharmacists to allied health professionals. And so we've got some 2013 supply numbers and a couple of 2012 supply numbers you can see for primary care physicians, psychiatry physicians, advanced practice providers, both the NPs and the PAs, a couple of behavioral health providers or allied health professionals, so the marriage and family therapists and the substance abuse and behavioral disorder counselors. And you can see the number of those types of providers we had in the U.S. As of 2013. We look ahead to 2020 or 2025, and the projected demand for those all increase fairly significantly. So 21% increase for primary care physicians within the next handful of years, and so forth for the rest. Pharmacists and radiologic technologists, we have 2012 supply data, and then some coordinating 2015. I'm sorry, that's a typo. That should be 2025 projected demand. And so, you know, we're going to need more. We're going to continue to need more of all of the various types of healthcare providers, and some of the most common ones I've chosen to list here. The search for quality healthcare professionals is becoming more competitive. We know that. And while we still do need to continue to recruit for these types of healthcare professionals, we also need to start making a shift in the way that we think and placing maybe not all of our eggs in one basket in regard to recruitment, but we need to start thinking about retention and how can we retain the employees that we currently have. So how are we ensuring that they feel cared for, that they feel valued and appreciated, so that they'll stay, and we can kind of get out of this cycle of the revolving door where we're constantly recruiting. And so we want to make sure that our employees feel valued and happy. And so what is employee satisfaction? So the Mountain States Group has defined employee satisfaction as the fulfillment, gratification, and enjoyment that comes from our work. It's not just the money or the fringe benefits, but the feelings employees receive from the work itself. And so Dale Carnegie said, people work for money, but go the extra mile for recognition, praise, and reward. So oftentimes rural communities, so we'll go back to the money thing. People work for money. We all need to work for money. But oftentimes rural communities, they can't compete with the salaries of their urban counterparts. So therefore, rural employers need to pay special attention, or even more attention, to ensuring that they have a culture of care and appreciation for their not only their current employees but for their future employees. So the Rural Health Research Policy Analysis Center did a study where they looked at 11 various allied health professionals. They determined from the study that the national average wage for these 11 various allied health professionals was higher in a metropolitan area than in non-metropolitan areas. So on average, the rural hourly wage was 12% less than the urban wage. And I think they did take into that there is a difference that varies between the profession and by geographic area. Some of the allied health professionals that were included in the study were occupational therapy assistants, physical therapy assistants, respiratory therapists, pharmacy techs, and so forth. And so, yeah, these allied health professionals are making less money in rural than in urban. However, this is not necessarily the case for physicians. And so a 2012 report by the Medicare Payment Advisory Commission showed that rural doctors actually make slightly more money on average than physicians practicing in the larger cities. And in January 2005, the Center for Studying Health System Change reported that rural physicians made about 12.7% more than their urban counterparts, and that was taken into consideration after incomes were adjusted for cost of living and so forth. And I do see that that oftentimes a physician can make a little more money in a rural setting, and that can be for a variety of reasons. It can be that rural facilities have to pay a larger signing bonus because they don't have the amenities, or they don't feel like they have enough to attract a physician, and maybe their salaries are a little bit more because they have a harder time recruiting. Oftentimes they will see more patients in a day than in an urban setting because there are fewer providers. So there's a number of factors that go into that. But money aside, at the end of the day, we do need to ensure that our current employees are feeling really appreciated and valued, and that leadership is really continuing to make sure that they're engaged in the work that they're doing. So from my experience in working with these rural healthcare organizations over the past several years, and also having conversations with rural health providers, you know, we've collected insights on what unhappiness looks like and some of the ramifications of having unhappy healthcare staff. And so what does unhappiness look like? So some of the warning signs that leadership really needs to pay some special attention to would be a lack of work commitment. Are your employees showing a lack of commitment to their work? Are you seeing more communication breakdowns than necessary? Typically, there'll be more mistakes and errors happening. Employees may be a little more irritable, showing some cynicism. And then absenteeism. When someone's not engaged in their position and they're not feeling valued or worthy, they oftentimes are just not showing up to work. And so these warning signs ultimately are going to lead to lower quality of care, the lower levels of productivity, poor customer service, patient dissatisfaction, and also a rise in healthcare. And not only does an unhappy staff affect the clinic and hospital, but it's also when they're having these types of behaviors, or if they ultimately leave the community or leave the practice opportunity, it's really disruptive to the patients of that facility and also to the community as a whole. And so that leads us to the cost of employee turnover. And so what really is employee turnover? So employees, they're not happy, and so they're leaving. They're thinking the grass is greener, I can make more money over here, this, that, and the other thing. They're leaving, and so it's putting these facilities in this constant need to recruit. And so we want to change that, and once we can get employees hired on, we want to do everything we can to ensure that they're going to stay long term. The best form of recruitment is ensuring that your employees are happy and content in their positions within your facility, and that you're fostering this culture of engagement and appreciation. There's a high cost that comes with employee turnover. There are both direct costs and indirect costs related when an employee leaves a healthcare organization. Having trouble with my clicker here. Okay, so some examples of direct costs of turnover would include the need to pay out some severance or vacation dollars. Let's see. I'm sorry, I'm having trouble with my clicker here. Okay. Oftentimes you will have to, the facility would be paying some staff overtime. Maybe you have to bring in some locum tenens or some temporary staffing to fill positions in the interim. There's the cost of advertising for the new job opening, and then staff time spent screening candidates, interviewing the candidates, verifying credentials, getting them orientated into the healthcare facility and onboarded, and then any training that goes along with that new employee. There's also indirect costs of turnover. And so some of those indirect costs are reduced quality, reduced morale. You have a shortage of providers, and so therefore you have a loss in productivity. People are working overtime or wearing more than one hat because someone left or a few people left, and so that increases their workload. When someone leaves, you have a loss of that organizational historical knowledge, which is really important in your employees, and ensuring that your employees understand the mission and the vision of the organization. And then just it has an overall impact on the culture of the organization. When there's a constant revolving door and new employees coming and going all the time, it just really impacts the people who are working there, because they're constantly retraining someone or working extra shifts. It really wears on morale. And so it's not always just a monetary cost when a healthcare provider leaves an organization. So I did a little research on the costs in dollars to replace a few different healthcare providers. And so a registered nurse. So let's see, which one was this? This was the Robert Wood Johnson Foundation. They did 7 in-depth case studies, and they also did a study of 13 hospitals, and they reported that the average direct cost to replace a full-time registered nurse was $36,567. So that's the cost of replacing just one full-time registered nurse. I was speaking with kind of a friend of ours from the center. Her name is Kathy Johnson, and she is a consultant with Dynamic Advantage. And she's been a hospital administrator CEO most of her career, most recently at the Johnson Memorial Health Services in Dawson, Minnesota. And she was sharing with me that she just hired a nurse practitioner. And it cost her $125,000 to bring in this new NP. They paid a recruiter $20,000. They had to bring in a locum tenens provider in the interim, which cost them $40,000. They gave the nurse practitioner a $10,000 signing bonus. They gave her $5,000 moving expenses. And then 6 months to get her onboarded, orientated, and trained, they figured was about $50,000 in staff time. So $125,000 for one nurse practitioner. And then we go to primary care physicians. So that number jumps to more than double the nurse practitioner at almost $300,000 for the recruitment of a primary care physician. And so I'm seeing a question: are these figures for rural or in general? These were for rural. These particular numbers. So the recruiting cost for a primary care physician, and this came from the Association of Staff Physician Recruiters, and so the average cost for recruiting a primary care physician was, they spent $10,000 on sourcing, $30,000 professional fee in sourcing, $31,000 on interviews, which include travel and entertainment while the physician was in the community. Let's see, signing bonus of $30,000, $15,000 moving expenses. The startup for the new physician was $211,000. So it's a hefty amount to bring in these new physicians. And if you then want to factor in the annual revenue loss, and so I'm going to take a step back. That was a 12-month vacancy. So that's how much it cost them it took them 1 year to recruit a primary care physician. And so that's the dollar amount that they spent in that 1 year. And then if you want to add on the revenue loss for that full-time physician that they were missing in that year was $990,000. So you add that to the $297,000, and now you're over $1 million for the recruitment of a physician. I would say there's no hard and steady rule that it costs more to recruit a rural physician than an urban physician. You know, like it depends on, you know, if you're doing it all in-house, if you're hiring search firms and recruitment firms, you know, that can be really spendy to utilize. But typically the rural areas have a harder time recruiting, therefore they spend more time recruiting. It's not uncommon for a rural facility to spend a year to recruit a physician, where their urban counterparts can also or can typically recruit a little bit more quickly than the urban counterparts. So it could end up costing the rural facilities a little bit more in their recruitment. Also because they typically will pay a little bit higher signing bonus and offer a little bit larger salary because of the recruiting issues that rural faces versus urban. Let's see here. So keeping a close pulse on employee satisfaction is important, and it should be part of any healthcare organization's recruitment and retention plan. And so to assist our networks and their partners and their members with healthcare provider recruitment and retention efforts, RHI developed a recruiting for retention plan toolkit. And so what is a recruitment and retention plan? It's merely an organized list of critical activities that ensures timely placement and lasting retention of quality healthcare professionals. So why is a recruitment and retention plan worth the effort? It's worth the effort because recruitment can be very costly and time-consuming, and so therefore it's essential that you have a really well-designed plan to follow. This plan starts with assessing need for a certain type of healthcare provider, and it will walk you all the way through the integrating of a new hire into the medical facility and into the community, and even take you through exit surveys when someone leaves. So it really is a step-by-step process that should be followed that will really help with the recruitment and retention of rural healthcare professionals. And so we talk about recruitment and retention, and so we often say a lot, you want to recruit with retention in mind. And so why do we want to do that? And the reason is because recruitment is episodic and retention is an investment. So recruiting includes activities such as starting to or learning to understand your workforce need within your organization, identifying the key attributes of a needed position, working to find potential employees that fit the need and match those key attributes. Whereas retention requires more of an investment with a long-term view and includes activities focused around how an employee relates to their work and also to the people in the organization. And it's not always just the hospital or the clinic's job, I guess you would call it, to recruit healthcare providers to your rural communities. It's important that you bring in community partners as well. They're an important part of the recruitment process. For one, it shows that the community is an engaged partner and it strives for quality healthcare in their organization. And it also reduces the workload of the healthcare facility. And so just a really quick example of some people in the community that you would bring on as part of your healthcare recruitment and retention team would be realtors, financial institutions, public school systems, places of worship, civic groups, maybe your paramedics or your police and fire department, anyone who can help contribute ideas for not only keeping providers happy in the facility, but also keeping them happy and want to stay in the community itself. And so just a really quick peek at RHI's Recruiting for Retention Plan Toolkit. So the toolkit, and we've shared this with many of our networks, specifically the Allied Health networks. It includes a Recruiting for Retention Guide, which is an instruction manual that takes them through the creating a rural recruitment and retention plan. Part of that toolkit included an assessment tool, which was an instrument that the Allied Health networks used with their healthcare member healthcare organizations to assess the clinic and hospital's current recruitment and retention plans. The next part of the toolkit was a summary template where the networks then looked at the completed assessments from their member healthcare organizations to see if there were any themes or the areas that they were lacking in a quality recruitment and retention plan. And then they created an action plan template, which they chose 2 or 3 areas that scored lowly on the assessment that they felt that they could assist their member organizations in kind of beefing up their recruitment and retention plan. And then it also contained a document full of samples and templates for various things that they would need, such as employee satisfaction survey templates, marketing plan templates, evaluation plan templates, performance agreements templates, and so forth. And so as I was just kind of explaining, the Allied Health networks had a hiring/recruitment and retention plan deliverable, and so this is where we presented them with the Recruiting for Retention Plan Toolkit. And I wanted to just share a couple of the areas, the common areas that the Allied Health professionals are currently working with their member organizations on. They're assisting their rural clinics and hospitals in their prospective states in developing employee mentor programs. They're helping the hospital or the hospital to add community members to their internal recruitment and retention teams. They are developing and administering employee satisfaction surveys, and then also helping to build stronger community and practice over practice opportunity overview content. And so what that is descriptions of the practice opportunity or the job opening, as well as the community for marketing purposes. So they're all doing some really good work in those and more areas within recruitment and retention in their communities. So at this time, I'm going to turn it over to Cap, and she's going to take us home.
Great, thanks, Angie. I'm going to pick up on those strategies that Angie was just talking through that the Allied Health Network leaders had found as opportunities for improvement in the recruitment and retention plans of their members. There are a few questions that routinely show up on employee satisfaction surveys. So, and I want to speak to that a little bit. They catch my attention as a team leader, a coworker, or an employee. They all are asking how well the organization handles change. So on that employee satisfaction survey, there's questions that approach this topic of change from different angles. A question may be, how well does the organization or department perhaps communicate? Or how do you feel about the planning that takes place here? Maybe the question on the survey is more direct. Communication is effective at keeping me up to date on changes, true or false. Sometimes the questions are less direct, but nonetheless, they do point to how staff are handling changes and how engaged they are in new ways of working. A question may be, I have a clear understanding of what is expected of me, or I feel that I'm contributing to the decisions this team is making. These are questions on the survey because organizations that are paying attention know that change can be difficult, and they want to keep an eye on how their staff are handling it. The next obvious question is, so what? What can an organization do, or a team, or a department, when results from these questions show a problem, show that staff aren't handling change very well? Staff may be becoming unhappy, a bit frazzled, uncertain of their role. One thing that organization development scientists have found about change is that there is a pattern to how people respond to change. You can see the hill in this diagram. This diagram illustrates the pattern, showing a dip in employee well-being or emotional states, that's the vertical axis, before a rise to at least the level of well-being when the change takes place, and this adjustment takes time, which is the horizontal axis. When we notice that variance in the impact, the loosely managed change process is the blue diagram, and it really dips. And you compare that to the well-managed process, and there's a pretty big dip, and that speaks to how we manage change. But the point I'm making is and the connection to this discussion on retaining staff, is that many of the items that describe what unhappy looks like show up on this diagram of employee well-being. Mistakes are made, there's communication breakdowns. In that dip, there's probably irritability, lack of work commitment, and maybe even that absenteeism that Angie was pointing out. With this insight and knowledge of this pattern of change that happens, what can we do that will help retain staff by addressing this pattern of change? Most people use the term change and transition interchangeably. However, William Bridges, in his book Managing Transitions, Making the Most of Change, points out that change and transition are two different things. Bridges helps us answer our question, what can we do to help people transition with the intention of improving retention? Change is an event. It's observable, it's situational, it's even actually external to ourselves. It starts at a particular point in time, and it sets into motion the transition process. Transition is psychological. It is a three-phase process that individuals go through over time to come to terms with an external change. So William Bridges is saying, unless transition occurs, change will not. And I'll add that the point of bringing this topic of change and transition into this webinar on retention strategies is that acknowledging that psychological impact of change and proactively addressing it. Those are strategies for staff satisfaction and improving retention. Here is the same diagram in a little bit more simplified image of what happens with individuals as they transition due to a change. The curve has been referred to as the valley of despair because no matter what, after a change is introduced, the emotional well-being of those involved goes down before it goes up. Bridges gives us both language and insight into the three phases of individual transition. The key to those working to address employee satisfaction issues and to retain staff is to invest time and effort in managing the depth and duration of the transition. In the next several slides, I'm going to talk us through the three stages to provide you with clues to what to watch for and listen for to better understand the phases of transition, and also bring in some ideas that Bridges provides to us for how to support people in moving through the phases from endings, through the neutral zone, toward the new beginnings. The characteristics are clues of what people are feeling or doing for each phase of the transition. Any change, an event that takes place, starts with an ending. It's leaving what is known. So Bridges calls this an ending because it's people react to and look for what's not there anymore. So they actually experience anger, despair, grief, perhaps loss of identity. Maybe it's the ending of someone's former role. Maybe it's the ending of a known process, such as using paper or medical records, or working differently with teams to provide care. Perhaps we've been very proficient at the way it used to be, and having to learn a new way threatens our sense of self, or perhaps even our identity. And as people move through this ending, they enter a period of heightened chaos and confusion. So they move into the neutral zone. Things aren't how they used to be, nor are they like they will be in the future. It seems easier to turn around and go back to how it was, and common reactions are responses of disorientation or confusion, perhaps even anxiety. In the neutral zone, we find ourselves in an in-between place, and it's a time of wishing it was like it used to be. We used to be really good at a process, and now we're slow. We used to know the rules and expectations of our job. Now things are confusing. Finally and eventually, a new reality begins to form. Bridges refers to this as the new beginning. And we have new skills and habits. The environment starts to feel familiar. Common reactions include a sense of belonging and commitment, maybe, and even optimism. As leaders and supervisors pay attention and invest in their employees through these phases of transition, then the time people spend in a state of decreased satisfaction or discomfort is shortened. So I'm going to step through each of these phases with the perspective of being a leader or someone in a supervisory or a team lead role, so that we can think through some of the options of helping individuals transition through the three different phases. During the ending phase, an important approach would be accepting and openly acknowledging the reality and importance of losses. This can be done in one-on-one conversations, like using a coaching approach or perhaps mentoring. It's also a good idea to support people where they are and not to make judgments. Some people say that you can't over-communicate. Well, that probably is true in this ending phase. Another insight that Bridges shares with us is that transition happens with individuals, not whole teams, not whole departments or organizations. For example, there are some folks that hate the idea of getting started with something new. Others can't wait to change it up. We have all experienced this with those we work with, those we live with, those and ourselves. As individuals, when we see the known, experiencing the ending, and we move into the unknown, which is the neutral zone, it can create a wide range of emotional reactions. The ramifications to us as leaders and supervisors and those wanting to invest in our workforce is that each of the unique individuals on a team, department, or organization transitions uniquely. What is needed is careful listening for where individuals are in their transition and consideration of what you can do as a leader or supervisor. Investing in that person to manage the duration and depth of the transition. Now that we're in the neutral zone, this time between endings and new beginnings is where people get distracted and disoriented. They may be experiencing anxiety or maybe are idealizing the past. To shorten this time, we need to be thinking about what we can do to help with interventions and actions and approaches that invest in our staff. This can be a difficult one, but it's important to resist the impulse to push people through the neutral zone. And that's because the neutral zone is normal. And if you backtrack on a change, undo it when people are in the neutral zone, they'll be relieved that they don't have to go through the change. But they were in the transition process. Another good idea is to help people talk about what they're experiencing. For example, have intentional discussions to explore how the transition is going. This is a time of strengthening team connections and being open to creative opportunities. Learning from the past and considering new options is when innovation can happen. The neutral zone can be a very creative place. When we're walking, we live through the bridge's transition phases, starting out steady, one foot firmly on the ground. But with each step, we pass through a neutral zone where we're not steady, where both feet are barely touching the ground. At this point, it's easy actually to tip us over. But then we land on the next foot and become stable again. This is a metaphor you all can think about of the transition phases that Bridges is bringing to us. Now, during the new beginnings phase, Bridges gives us some specific ideas to encourage staff in this moving into this phase that may be marked by clues of hope and commitment and perhaps a sense of belonging. This is a time to clarify mission and vision of where we're heading to with the change and to set high goals and manageable steps and continue to support, reevaluate, and make course corrections. That is always a good idea. Change is normal, and so are transitions, and all transitions for all people include a dip in the emotional state of those individuals. This really is human nature, and the strategy for effectively retaining staff and proactively addressing staff satisfaction and engagement is to manage that duration staff are in transition. Angie and I wanted to develop this presentation so that we had some time for conversation. I'm hoping that if you guys have specific questions on the content that Angie or I provided in retaining workforce to address the demands and shortages in healthcare, it'd be great to hear them. I've posed these two questions to get us kind of started with our thinking, because healthcare and retaining our workforce is complex and difficult. It's a good thing for us to talk about a little bit. So, star 2 to unmute if you have would love to be part of this conversation. For those in the computer, we can use the chat box if you'd like, but I'd love to hear your voices as well. What was an aspect? Yes, please.
I wasn't sure if you're opening up the floor. I thought that it was interesting to see how much it costs to replace staffing. I thought that was really interesting. It really showed the need to retain staff.
Mm-hmm. Yeah, they're powerful numbers.
Yeah, those are really powerful numbers. And I'm just wondering what your thoughts are, too. I can only speak from having worked on a reservation for a little while where staff were very transitory there. And I remember the community, because they knew that staff would sort of trickle in and trickle out every 2 years, had sort of a different perception or a different feeling towards their providers because they were so temporary. Do you have any suggestions or things that could be done like to get the community to be more accepting in a way of providers because of this sort of weird relationship where some communities might, not be as warm or welcoming because they feel like it's such a short-term commitment?
That's a good point, Jane, and I am going to have Angie respond to that, but I've got just something that will build off of that as well before I pass over to Angie. And when I lived in a small community, a totally tiny community, and so I can relate to your experience on the reservation time. This was an agricultural community in northwest Minnesota, and I've been doing some key informant interviews with them just recently, actually, getting ready for some strategic planning, and the community members are talking about their lack of connection to the healthcare providers that have been coming through over the last few years. They've been having trouble getting folks to stay. And then in my own personal experience living in that tiny town, I was a newcomer, so to speak, and folks would refer to me as the place I lived like 2 generations ago, right, was the name of the farmstead that I was living on. And for me as a community member, that was always felt like I was on the side. So there's a certain aspect of getting our community members to welcome and embrace, which is a little bit, the point I'm making is a little bit contrary to how some rural communities work. And they have a culture of looking to their own and not really trusting folks that are from out and about. But Angie does have some experience and some suggestions around building that community into the retention planning piece. So Angie?
Yeah, it is hard. The rural communities do kind of suffer in that area of not having, long-time relationships, and it's typically more so with their primary practice physician. Oftentimes the rural areas are designated health professional shortage areas, which enables them to then employ foreign medical graduates or foreign physicians, and the foreign physicians that are signed in a rural community only have to stay there for 3 years before they can get a green card to work anywhere within the U.S. And it's hard to find those foreign medical graduate physicians who will stay in a rural community more than their 3 years of obligation because of the lack of amenities or the lack of maybe a diverse population in those areas. And so it is something that rural people, rural citizens struggle with. And so I agree, making or inviting them to be part of the recruitment and retention teams. And again, this goes back to more physicians because physicians are the ones that are probably the type of provider that they're going to have the closest relationship with. Making sure that the community is very welcoming to a new physician that comes to their community, making sure that their spouse is actively engaged in the community and assigning a mentor to the spouse of the physician who's coming. The number one reason a physician leaves a community or a practice is because their spouse is not happy there. And so whether it be assisting the spouse in finding employment or assigning someone from the community to that spouse to make sure that they're getting the answers that they need and helping to integrate them into the community and helping them find things of interest to them, whether it be choosing schools or finding a place of worship, getting them involved in civic organizations and so forth. And then also another way to detract from that revolving door too, and this is can certainly be done for physicians, but for allied health providers as well, as growing your own. And so really working to, with healthcare or with graduating high school students or planting that seed in middle school and high school with these students, that live there already and get them in these training programs, because if they were born and raised in the community, typically they're going to stay there. Or if they leave for a short time, a lot of times they do come back. And so looking at your displaced workers in the community, the veterans in your community, and working on getting them some training in the areas that the healthcare facilities need. They're already familiar with where they're at and live there because they live there.
True. Thank you.
Other thoughts on how perhaps we as both TA providers and project officers can support our grantees in retaining workforce? Marsha, I see you're on the line. Could you speak a little bit to?
I was going to say we can share your toolkit.
Yes, share the toolkit.
I didn't know that you would need one, so this is good.
Yeah, it has a lot of good parts to it. I know with the Allied Health folks, we've been working with some of the network leaders to help them understand things, and I'm going to have my OD hat on, of course, but helping them understand things like change. So recognizing that when you bring somebody into a new team, that onboarding piece is really, really important, because the new team member changes things, even if they are from the community. If they've just started working in a healthcare organization and they're new to a team, that needs to be considered carefully. And so leaders of those teams can really make a difference for retention.
Yeah. Is it unmuted?
Yeah.
Okay. Sorry, this is Cassie. I was just going to comment, and I don't know how many of our grantees are really doing like employee satisfaction surveys. Maybe they don't want to open up that can of worms, but I mean, a lot of the symptoms of like unhappy employees and like kind of what leads to that turnover, I think maybe it would be useful to do employee satisfaction surveys, but then of course you also have to supply them with the skills and kind of knowledge which the toolkit contains to be prepared to address that, or, you know, helping managers understand like these signs, like if there is a lot of absenteeism or breakdowns in communication, and that those are warnings. And also sometimes I feel like in some of our grant programs, they're just so like desperate to hire anyone. Sometimes they hire someone who isn't an ideal fit to begin with, because there's always that balance of we need someone, and there's not always like the strongest pool of candidates, so you have to make some kind of a decision. So yeah, I was just thinking that, you know, having conversations around that, and then also giving managers and employers tools to address like when employees are unhappy and like what options they might have to, you know, perhaps fix it or improve upon it.
Hey, Kathy, this is Angie. Oh, go ahead,
Yeah.
Kat.
No, please, Angie.
I was just going to say, I agree. Sometimes healthcare facilities they get so desperate and they look to just maybe hire that warm body just to fill the spot, and they may not necessarily be a fit. And the outcome of that is chances are they're not going to stay. With the Allied Health group, the Allied Health grantees, when they did the assessment with their member healthcare organizations, we did learn that most of the healthcare facilities were not doing employee satisfaction surveys. And we learned that most of them are not because they didn't really have any competition of other healthcare facilities within a daily drivable commute. So the healthcare workers in that facility either worked there, or their other option was to have a long commute to a neighboring town that had a healthcare facility. So they kind of had to stay there. But the point that we're trying to drive home to the leadership in those communities or in those organizations is, you know, they may have to stay there, but they don't have to be happy. And if they're not happy, then are they providing quality care? Are they making mistakes? Are they having issues with absenteeism? They could still be having all of those negative behaviors that could be impacting patient satisfaction and quality and reputation of the care facility in that area. So it's still really important whether the employees have an option to work elsewhere or not, that you have your employees engaged. And so we do have employee satisfaction survey samples, and we teach or we have education on that when you do an employee satisfaction survey, you do need to follow up. You need to be very transparent during the process. You need to share the results of the survey with the staff. You need to share with them which areas you recognize that scored low and need attention, and that you're going to be working on those areas. Because if you survey just a survey and nothing happens, no change follows the survey, then people are going to quit even completing the survey, and you're going to be in the same boat as had you not surveyed in the first place. So we do share that, teach folks how to create action plans on, choosing a couple of areas within the employee feedback that they want to work on, and how to get that done, and how to communicate progress with employees and so forth.
This is Marsha. Just real quickly, because I know we don't have a lot of time, but I love the chart that you did, Angie, on or Cap, on the supply and demand, and I'm wondering whether or not you have one specifically for allied health, because I would certainly like to see that. And secondly, I think that it's just so it's so awesome when you really kind of think of retention as an investment, and if we can just get that in the mindset of those that are doing the hiring, that particularly I think it's a little bit different, but particularly for the projects that we are supporting, because what we want them to do is to not only to retain but sustain, and sustain that which we have been able to support them in starting. And so if I don't know, maybe even if there's some way that with all of our grantees, with all our projects, if we can just let them know that this is an investment. When we're talking about sustainability, we're talking about retention, and we're talking about an investment not only for that organization that we're funding, that network that we're funding, but for their region as well.
That's a good point, Marsha. This is Cap. And when we were approaching the deliverable of having a recruiting plan or a hiring plan, that's really where our recruiting for retention toolkit came out of. And we've worked really hard with the allied health workforce, in particular grantees, to get that thinking that even as a network, if you're working to recruit people for your members, that's not where your job stops. Your job doesn't stop until your members are really good at also retaining those people that you're working so hard to recruit. So I really appreciate that thought. I'm going to switch us to our closing template, just so that if folks have a chance to give us some feedback, we